Good morning. Thank you all for coming. I'm Peggy Chapman, political nurse specialist in psychiatry and Hingham, and I'm going to introduce the panel and have them each speak a little bit about their work. And I'm going to also ask them to be specific. I know some of their work is very specific to their area, but then also Beth especially, and Mark maybe, and Nancy, to specifically talk about kind of the entry point if the child shows up in your office with symptoms, what is it you do, what labs you might run in a practical way, pediatric level, and then also for Mark, particularly what would happen to a referral level to a PANDAS clinic or some specialist. On the left, yes, is Dr. Beth Latimer from Georgetown University in home private practice. Child neurology. Mark Pasternack, who's infection control and infectious disease. Sorry, yes, that's a nursing term, infection control. At Pasternack Hospital and part of the pediatric PANDAS clinic that's just recently been formed. Nancy O'Hara, who's a private pediatrician and integrative functional medicine physician in Connecticut, has a large practice both with kids with PANDAS as well as autism spectrum. Madeleine Cunningham, who is a specialist in strep and has created the Cunningham Panel, which helps us identify antibodies that are causing some of the issues in the brain. And our most important guest, probably the originator of PANDAS, Dr. Susan Swedo from National Institutes of Health. And I think we're going to start with you, Sue, to talk about it.
If you could use the microphone.
Yes. I know I should do the same thing.
As you'll now hear, I have a very bad cold, so I'm making my colleagues quite anxious. I am Sue Swedo, and it was actually our team that found the PANDAS subgroup back in the late 1980s. At the time, we were looking for a molecular and medical model of obsessive compulsive disorder. We actually worked with Dr. Louise Kiesling from Providence, Rhode Island, and Brown University to do a series of studies documenting that children with an unusually abrupt onset of symptoms had antineuronal antibodies that were recognizing the basal ganglia. And we talked about it yesterday that this is actually a rediscovery of a rediscovery. The first reports of this were in 1915 to 17 after the very bad influenza outbreak. And then in 1976, John Husby had described antineuronal antibodies in lupus and in Sydenham chorea, and the distinguishing feature was that those antineuronal antibodies in Sydenham chorea were also cross-reactive against the strep. So that's a lot of history, and I'm only supposed to talk for 2 minutes, so that's all the history you get this morning. Fast forward to 2010, I thought that the controversy had reached its peak with a group of neurologists claiming that this disorder didn't exist, and if it did, it wouldn't have the hypothesized etiology. That plea or that case had been made a number of times in the neurology journals, and we met at the NIH in July of 2010 to try to come to a compromise. Dr. Noel Rose from Johns Hopkins worked with us, and in the planning calls leading up to it, I don't think I've shouted that much in my life, but it was actually a very productive process because Harvey Singer and Ed Kaplan shouted back at me, and we had a good time. So we went into the meeting expecting that we would be able to meet our planning committee's goal of coming to agreement on a clinical presentation, leave the etiology off the table, leave the strep off because that was the area of controversy. Supposedly, after 2 days of sitting in the same room, it became very clear there was not going to be unanimity, but the vote was 38-3 to call this new clinical group PANS for pediatric acute onset neuropsychiatric syndrome. The 3 neurologists voted for CANS, childhood acute onset neuropsychiatric syndrome. And if you keep up with your literature, you know that their paper was published in the Journal of Pediatrics in 2012. And a few weeks later, ours was published in Pediatrics and Experimental Therapeutics, which unfortunately is an online journal that's not indexed in PubMed. So you can get it through Google Scholar, but you can't get it through regular ways. And I think that the controversy actually increased rather than decreased. So where does that leave you guys? It leaves you hanging out in the wind, because if you accept that this condition exists and do the appropriate workup. So I'm very happy to report that because of work with colleagues in the autoimmune encephalitis field, PANDAS and PANDAS can be considered a form of autoimmune encephalitis, and there is a regimented treatment for that. The main thing I want to urge is recognition, and I'll pass it on after just reminding you of the symptoms that are on your handouts. OCD, or an acute onset of eating disorder, 4, 5, 6-year-old children that start food restricting to the point that they lose 3, 4, 5 pounds, which when you only weigh 40 pounds is 10% of your body weight. And when that happens, they begin to develop the body image distortions. In addition, they have 2 of 7 symptoms that include behavioral regression, acting extremely young for their age. We've had 10-year-olds who start crawling around on the floor, talking baby talk, playing with baby toys. Irritability, aggression, personality change, a very abrupt change in the child's demeanor, as well as their ability to sort of tolerate any kind of changes. Sleep problems. My colleagues are documenting now that these children have not only the initial insomnia that the parents report, going from 15 or 20 minutes to fall asleep to now going to 2 or 3 hours to fall asleep, and then waking up multiple times in the night, new onset of night terrors, new onset of other parasomnias. In addition, they have urinary symptoms. Mike Piccichero first described this in 2002, documented that in their large pediatric group, 8 out of 12 children who met the PANDAS criteria actually presented with urinary tract symptoms, urgency, frequency, new onset of bedwetting, and daytime accidents. Where are we gotten to? Motor and sensory hypersensitivities, the motor tics, choreiform movements, as well as sensory sensitivities, light, sound. Is almost like not almost like, it is an encephalopathic process. And they have extreme light sensitivity. And the final thing then is sort of the other psychiatric symptoms of extreme separation anxiety, depression. The obsessive compulsive thoughts can actually blur over into depressive thoughts, and probably the most dangerous combinations are the children who won't eat because they feel that they're not worthy of it, or they have a fear of choking or vomiting, or the children who have extreme thoughts of harm coming to themselves or to their parents, and they actually are impulsive enough that they act out on it. So that's who I am and what PANDAS is.
Yes, I'm Madeleine Cunningham from the University of Oklahoma Health Sciences Center in Oklahoma City, and I've been there about 32 years and am a professor of microbiology and immunology. And I began my studies 32 years ago in streptococcal diseases, and my training for my PhD was also in streptococcal diseases at the University of Tennessee in Memphis, with the actually people in infectious diseases there rather than the microbiology and immunology faculty, although my PhD is in microbiology and immunology, with training later in Oklahoma City at the Oklahoma Medical Research Foundation in protein chemistry. So I opened my lab in the mid-1980s, or actually began at OU in 1980 and opened my lab to study streptococcal sequelae. I'm sure all of you have heard of rheumatic fever, and you've heard of Sydenham chorea, which is the major neurologic manifestation of acute rheumatic fever. And I do, if you've never seen it, which probably all of you have seen Sydenham chorea, I do have a video of that on my computer that you could observe today if you would like. But First of all, we began studying the heart, and so we did that for about 15 years, and then began to study the brain in addition to the heart, and how autoantibodies could affect both the heart and the brain. And about that time, Dr. Swedo called me and asked me to help with her studies in PANDAS. And we began to look at the autoantibodies that were present first in Sydenham, Korea, because she had a large study of Sydenham, Korea ongoing. And we studied the autoantibodies from those patients, and she also was treating with plasma exchange and found that those patients were actually so improved in 48 hours that their symptoms were almost completely alleviated, which suggested that autoantibodies might be at least a partial cause of the disease. And so we published our first paper together in Nature Medicine about Sydenham, Korea, and how the autoantibodies in that disease actually signaled human neuronal cells. And the measurement for that was an enzyme called CAM kinase, and that is one of the tests in our company. And we subsequently identified several other autoantigens, including tubulin and lysoganglioside, both very prevalent proteins in the brain. Then we went on to realize that the signaling we needed to investigate receptors that might be the basis of the signaling. And we determined that the dopamine receptors D1 and D2 were important in the autoantibody production in this disease. And that made pretty good sense from the standpoint of the choreic movements. And predating the choreic movements in Sydenham, Korea, is a neuropsychiatric symptoms such as OCD predate the choreiform movements. And of course, parents and doctors miss this. And in the case of PANDAS, the choreiform movements are so small that most doctors miss that also. And we have been able to subset the PANDAS group into two groups, those with the choreiform movements and those without. And those without actually don't have antibodies against the D2 receptor, the dopamine D2 receptor, where those with the choreiform movements do. This is very new data, and we're getting ready to publish this with Dr. Harvey Singer, who we've investigated his group of patients that are more chronic, and he and several of the neurologists felt like PANDAS, quote, didn't exist, but now, of course, that we have been able to understand why they couldn't find the D2 antibody, then of course it does exist. They're all positive with the CAM kinase test, and then of course you can subset the two types with the D2. And both antibodies against the dopamine D1 receptor and D2 receptor are present in Sydenham, Korea, and the PANDAS with the choreiform movements. And the ratio of antibodies is equivalent or correlates with the patient's symptoms, and that is actually published. It's an online journal, PLOS ONE, but all of our papers, for the most part, are in the Journal of Immunology, and I had already said Nature Medicine, the Journal of Neuroimmunology, so they're easy for you to look up, or easy for us to show you those papers. And our website for the testing for patients is www.moleculara, moleculara.com, and those papers all of our publications to date are shown on that website. We have an animal model where we immunize with strep, and when we do that, we show that behaviors that are abnormal, meaning obsessive behaviors and movement problems, mainly holding the food pellet. But these can be resolved with haloperidol or SSRIs in the animal model, and passive transfer of the antibodies also helps bring on the behaviors. So it's very similar to what was found in Sydenham, Korea, and PANDAS. I think with that, I'll pass it to...
I'm Dr. Nancy O'Hara. Let's start with the napkin down now.
I'm sorry, both of us. I took a cold last night, so I didn't touch it.
I'm a pediatrician in Wilton, Connecticut, and I have a consultative integrative practice. I started about 15 years ago for children on the autism spectrum and with neurodevelopmental delays. And about 4 to 5 years ago, we started to have a great influx of children with PANDAS and PANS. We try to look at the whole child, and certainly part of our initial workup is the questionnaire, because I think we really, this is a clinical diagnosis, and we really try to look through that questionnaire at the timeline of the illness, as well as any other symptoms that the parents may not even realize be part of it. Certainly a lot of parents don't know about the sleep disorders or the urinary problems that these kids have, and discover that through the questionnaire. Once they come, if we think this is part of the problem, a lot of our initial workup, all to regular labs, are inflammatory markers, certainly strep titers, mycoplasma titers, and in our area, extended Lyme Western blot and co-infections. And then inflammatory markers looking at, CRP, sed rate, CBC, and some strep pneumococcal serotypes or other vaccine titers just for immunocompetence. And then in the kids that we have a high suspicion from the questionnaire, we'll also do Madeleine's panel as part of their initial workup. With that, we also may get some antibodies. We see certainly kids with thyroid antibodies. Even without frank thyroid abnormalities, the thyroid antibodies are often elevated. And then we have a subgroup of kids that also have metabolic and mitochondrial deficiencies. And in those kids, based on what we get from their history and their physical exam, we may also include that in their workup, looking at carnitine, acylcarnitine, ammonia, homocysteine, lactate, CK as part of that workup. So we try to look at a very comprehensive panel to try to help decide, are there other things that, in addition to the treatments for the PANDAS, whether it be antibiotics or immunotherapy, are there also other things that they may be deficient in? And as we talked a lot about yesterday, that may also include some vitamin and mineral deficiency. Certainly most of these kids are vitamin D deficient, and some are also zinc deficient. We'll be looking at that also. So.
I'm Mark Pasternack, and my involvement in this domain is really accidental, in the sense that I've been at the Mass General for over 30 years, and most of that time we had no structured outpatient pediatric infectious disease program. When outpatients needed to be seen, I kind of figured out a way to see them informally out in the clinic, and our former chief of pediatrics insisted that we have a regular scheduled pediatric practice, infectious disease practice, and that began 5 or 6 years ago, and it wasn't long after that that the occasional patient was referred either by Dr. Geller, one of our pediatric psychiatrists with an interest in OCD, or by some of the therapists engaged in cognitive behavioral therapy who wanted me to see these children for antibiotic management of their PANDAS. And I must say that, like I'm sure the majority of folks in the room at some point in time, were either unclear or skeptical about the picture. But I must say, with time, as I saw these children, it was really pretty clear to me that this was a genuine problem. And we've been seeing children with an increasing frequency ever since. In the last 6 months or so, actually maybe last 3 or 4 months, a pediatric psychiatrist, Kyle Williams, has joined us from Yale. Kyle was involved with Dr. Swedo in the current or latest iteration of the IVIG therapy trial, and has both a research interest in some of the physiology relating to PANDAS, as well as a clinical interest in this domain. And Dr. Yolande Walter, who's a pediatric immunologist in our department. The three of us comprise a kind of a troika of separate interests that hopefully fit together to create a coherent picture. And so we've tried to set up a more structured PANDAS clinic or PANDAS program. It's still very much a work in progress because the conceptual model was that children would be referred to Dr. Williams for sort of initial assessment and then triaged either to Dr. Walters for immediate consideration of IVIG therapy or to me for more antibiotic management issues and diagnostic investigation. It's just that appointments for Dr. Williams are now being booked out 4 months, and it's not logistically or practical from that point of view. And so we're trying to figure out how to get children seen in a more timely way. But we meet on a regular basis. Dr. Geller, who has a particular interest in OCD, pediatric OCD, joins us as well. And we hope to provide rational and coherent clinical care, and also to parlay this into a program of clinical investigation going forward. The question about what study should be done, I think Dr. O'Hara mentioned much of what we do. I'm not a huge fan of phlebotomy as treatment for this condition, and I've had children referred to me with pages and pages of lab data, antibody titers against many infectious agents, if not all infectious agents for which titers are available. And I find most of that information not helpful because there's no time factor enrolled in various IgG titers of any number of viral infections. So that the few treatable infectious causes have already been mentioned, and the list is short. Group A strep infection, mycoplasma infection. I'm not a huge proponent of Lyme disease testing, but everybody in our catchment area has a serious Lyme exposure risk, if not history, and I have certainly no problem investigating that as well. By the time children get to see me in the office, they virtually all have been on antibiotics for short or prolonged periods of time, but for those of you sitting where you're sitting, you have the luxury of seeing children for the first time from this perspective. And even in the absence of acute pharyngitis symptoms, this is one of those cases where I would swab every child who comes into the office. And if they have a positive rapid strep test or a positive strep culture, I think that is helpful. There's a discussion amongst our working group of PANDAS at our weekly conference calls about perianal cultures. It's hard for me, seeing a child who's been on antibiotics for 2 months or 3 months, to get too excited about doing perianal cultures, but I must say when a child comes into the office who's received no prior therapy, it's actually something worth doing. Perianal strep is actually an extremely difficult challenge to treat successfully and cure, and for years I've been waiting for someone to come up with a rational and successful program, because in fact children relapse commonly after conventional short courses or even several weeks of good antibiotic therapy to treat strep infection.
Are there particular symptoms that point to testing for that?
Well, so in symptomatic children with perianal strep, it's classically a younger child under the age of 5, often in the daycare or preschool category, and itching or just paternal or parental notation of erythema, perianal redness and soreness when they bathe their children that comes to attention. These kids rarely have fever, they're rarely ill, but you know, when they pull their pants down, there's clearly a big perianal rash. It's inflamed, and it's either going to be yeast or it's going to be strep, and it's not going to be yeast. So it turns out that that's something worth investigating. I might ask Dr. Swedo if how helpful those cultures have been in children who don't have obvious perianal erythema. But I just want to finish by mentioning mycoplasma testing. The conventional mycoplasma testing performs ELISA against IgG and IgM antibodies in this infection. And for those of you who've ordered this more than once or twice, you will see that the IgM is commonly elevated. And again, this is often in children who have no recent respiratory complaints, no current respiratory complaints, and don't have the appearance or have a recent history to suggest walking pneumonia. When you get a positive IgM test, you really need to have the laboratory perform a confirmatory IgM test. And there's an immunofluorescence test where they actually stain a tissue sample and the child's antibodies have to light up the mycoplasma, or else it's a nonspecific positive. IgM antibodies are very, very sticky in ELISA assays, and false positive IgMs are very common. And the only laboratory that I know that has consistently been doing that extra step for positive IgM test is the Mayo Laboratory up in Andover. Quest performs IgG and IgM testing, but they don't seem to routinely do the confirmatory test. And I would guess that no more than 10% of the positive IgM mycoplasma titers that I see turn out to be confirmed by the immunofluorescence testing. So before I put somebody on big doses of azithromycin in open-ended fashion, I'd really like to see a confirmatory IgM test. So I'll stop here.
Okay, I'm Beth Latimer. I'm a child neurologist. I actually work about 2 or 3 miles up the road from the NIH. And there is a genetic predisposition to this disorder. And I think that's what one of the things that has not yet been clearly identified yet. But because of the study that went on at the NIH, I initially started to see a few siblings who had been treated at the NIH successfully with plasmapheresis. And they came to me and said, my other child was treated, and could you please treat my other child with plasmapheresis? And I was like, well, wait a minute, let me look at the research and see what they did and what happened. And then I treated my first child, and then I treated my second child, and it's been my patients, and it's been about 12 or 13 years now, and I have a huge volume of patients that I've treated with PANDAS. And once you start treating the kids, they come to you because they go to their pediatricians and they say, I don't believe in PANDAS. That doctor's crazy. And this has changed in DC. It's definitely changed in DC. It used to be that 10 years ago, the patients would come in the first 15 minutes of the visit, I had to calm them down. You're not crazy, I'm sorry, it's gonna be okay. The medical community's just not accepted this yet, it's gonna be okay. And the kids were all really very acutely ill from a psychiatric standpoint. Now, the kids are coming in, most of them have had a course of antibiotics. They're at least on their way, and then it's a matter of how to get them back completely to normal. We have quite a little epidemic in the Washington, D.C. area as well. And there is quite an epidemic in Richmond, Virginia as well. So it's not unusual. I know there is this epidemic on the South Shore here in Massachusetts, but that's not unusual. And it's very difficult to get anyone to do anything about it. In Northern Virginia, we have one school that I have 10 children with PANDAS in one school. And I've tried to call the CDC, I've called the county, I've called the state. Really have not been able to get them to do anything. It's an interesting school because there's 50 children there. It's a magnet school for emotional disabilities. So there are 50 kids coming into that school who are identified as psychiatric illness, who are mainstreaming in and out of the school. So I wonder how many of those children actually may have PANDAS. I wonder if there are some of those children. So it would be nice to do that, but of course we can't violate children's rights to do strep cultures on them. So I don't know how that's all going to turn out. But in terms of the way I practice, I see a lot of kids. In neurology, just like in PANDAS, is no exception. 90% of your diagnosis is going to be made on your history. And you have to take a long and extensive history. It's extraordinarily helpful to have the records from the pediatrician. And often I will see a little blip at age 4 with a child presented to the pediatrician with urinary frequency for a month and urinalysis, rule out diabetes, rule out urinary infection. And then everyone throws their hands up and, well, it went away. And I had one child actually come to me, and the diagnosis on the pediatric record was acute urinary frequency syndrome. But a few of these kids have had VCUGs and things, and it just dissipated. But I also look at the growth curves, and because some of these children will have the anorexia, and you'll see oftentimes the growth curve just flattens out, and no one's really paid attention to it. And sometimes it's that prepubertal slowdown and all the other stuff that you see, but it's interesting. I always have the kids come with their growth curves, come with their pediatric progress notes, and come with handwriting samples from school, especially their handwriting journals, because the dysgraphia associated with this is dramatic and it's very characteristic. They write big letters, they don't close their O's, they have no respect for space on the page, capitals, small letters. And in the DC area now, the schools are actually fairly well educated. And I had a first grade teacher who was thrown into the closet and had a chair thrown at her and a few other things. And she'd been teaching for about 30 years. And she called the parents and she said, I don't know, just that child has strep, take him to the doctor. I've only seen this once before. A child had strep. So our schools are informed, and that's where it often gets diagnosed, because the separation of the school phobia is seen in the big dramatic episodes in about 85% of the time. So you'll see the little episodes often will lead to the big one, and when the big one happens, it's usually really, really big. And so the 90% is the history, but I continue to be astonished when I do physical exams at how often I see perianal strep, vaginal strep, gut-tape psoriasis, tonsils that are asymmetric with uveal deviation. It just continues to surprise me. I don't know if you have that same experience. It's just the kids are infected, or they've had the 6.9 strep infections in the last year. But often it's their own fault, because they go to walk-in clinics and they get diagnosed with strep. So pediatricians they don't have control over it, and they don't know how many times the child had strep. So I also try to get the walk-in clinic, records. And sometimes when you actually collect the walk-in clinic records, that the father took them one time, the mother took them another time, the nanny took them the third time, it's like there's 10 strep infections in a year. So you have to collect the data, and it's not always that easy. But it's fun, because when they get better, they get all better. And neurologists don't make that much stuff all better.
One of the main things that I think pediatricians struggle with is the antibiotic choice and the length of prescription. The standard treatment course of strep would be 10 days probably of some choice. But in treating PANDAS, many of us start with 30 days, for example. But I would like some of you to address that if you could.
30 days for me.
And which antibiotics do you think about first with PANDAS? First and second, probably, especially if you have a amoxicillin or a penicillin allergy.
I'm sitting next to an ID person, but
I think of the antibiotics for streptococcal infection as a step ladder that involves four steps. Amoxicillin is at the bottom of the stairway, and group A strep has never demonstrated resistance at the sort of testable level against penicillins in general and amoxicillin in particular, and in principle should be perfectly efficacious in eradicating acute streptococcal pharyngitis. The problem for amoxicillin is that the environment, the neighborhood, the tonsil or milieu is actually a tough place, and the non-characterized, unnamed normal flora of the tonsil and of the pharynx actually has an extremely high rate of beta-lactamase production. And so current estimates are that amoxicillin cures probably a majority of group A strep pharyngitis episodes, but by no means the vast majority, maybe 50 or 60% for some of the naysayers, and that you have to use a beta-lactamase resistant agent. And so cephalexin or some other first-generation cephalosporin is generally where I start in thinking about children with PANDAS, because I think we just need a higher level of efficacy in this complicated situation. I don't want to give a child a month or 2 or 3 of amoxicillin and have the child not show clinical improvement and then have the whole diagnosis thrown into question. And so except in the mildest cases, or in children with selective cephalosporin allergy, I almost always start with the first-generation cephalosporin. One of my colleagues is a big fan of cefadroxil, given once a day as suppressive therapy. I must say I haven't done that very much, and I finally tried it once in a college student who was having terrible recurrent strep without neuropsychiatric symptoms. And she called me 3 weeks later to say she had a positive strep throat culture at the University Health Service. And so I'm a little down on cefadroxil these days. But I use twice daily cephalexin as my standard therapy. And I tend to use it at a goodly dose. And I tell everyone that oral cephalosporins can be given up to 100 milligrams per kilo per day in treating a serious infection. So if a child, say, were sent home from the hospital with osteomyelitis or septic arthritis, the standard dose is 100 milligrams per kilo per day of the cephalosporin. That if you gave 50 milligrams per kilo per day or in that neighborhood, it's still a pretty generous dose and not at all a suppressive dose, but in these children it seems to be well tolerated and it seems to be helpful. For kids who don't seem to improve with cephalexin, I kind of go up one more step on the ladder, and I think of Augmentin as being the next step up on the ladder, amoxicillin clavulanic acid for children who are not allergic, simply because of the enhanced anaerobic activity that this combination agent has over first-generation cephalosporin. It's better at killing the bacteria that are making beta-lactamases. And I wish I could say that that's been perfect, but it hasn't been perfect. I will say that the current formulations, particularly the amoxicillin ES, or I should say Augmentin ES or amoxiclavulanic ES formulation, which has a relatively low dose of clavulanic acid relative to the amoxicillin, allows you to give a highish dose of amoxicillin without provoking a lot of diarrhea. When amoxicillin clavulanic acid was first marketed, it's literally about 30 years ago, parents said, "Oh yeah, I know that drug. That's amoxicillin with a laxative." They've ratcheted down the clavulanic acid component, not to an ineffective level, but to one that's well tolerated and still adequate for its protection. So you can give 50 or 60 milligrams per kilo of Augmentin, and typically without diarrhea, given twice a day. And the fourth step on that ladder for me is clindamycin. And I think clindamycin has always just given me the willies. I have no rational reason to be quite so fearful about it, but as you know, it's been forever linked with C. difficile infection. I have to say, having treated dozens of children with chronic antibiotics in this situation, I don't want to jinx anything, but C. diff in children receiving suppressive antibiotics in this setting is extremely low. And interestingly, for some teenagers or young adults who got a course or two of antibiotics for sinus infection or recurrent staphylococcal pustulosis who get C. diff, the younger children treated in this way have not had a big problem with it. And I think whether the incidence of C. diff carriage is at its natural nadir at this point or not, I don't know. But we've been blessed that you can give antibiotics in this way without getting into a lot of trouble. The problem with clindamycin otherwise is it can cause diarrhea in its own right, and for some kids that's a deal breaker, and for others it seems to be pretty well tolerated. The final thing is that for younger children, the suspension form is just hard. I would use worse words than that. If I can just tell one anecdote, I walked into an isolation room where a child was being discharged, and I walked in the room and I thought the kid had C. diff diarrhea. The room just smelled from high holy hell. And the dad said, "Oh, I picked up the drug," and he stuck the bottle in my face, and I nearly fainted. Whoever marketed this clearly wasn't actually doing a taste test to realize how unpalatable it is. And I know that some families have told me they've had good luck mixing this sort of one-to-one with straight chocolate syrup from the bottle. And as someone who likes chocolate, that doesn't sound so bad to me, but it doesn't always work, and sometimes it just doesn't work. So I've had some families get the smaller capsule size and open the capsule and sprinkle the beads on a small serving of something that the child likes to eat. And sometimes that works, and sometimes the moms will say to me, those beads don't taste so good either. So when clindamycin is tolerable, that's a final option. Fluoroquinolones get mentioned from time to time, and as I mentioned yesterday, there's a concern that's sufficiently important to the FDA that there are warnings placed on the drug that fluoroquinolones can produce tendinopathy, and that parents who take fluoroquinolones and then play tennis and get Achilles tendon ruptures know that the concern is real. And so it's one thing to use a fluoroquinolone like ciprofloxacin or levofloxacin for 10 days or 2 weeks, but to think about more prolonged therapy or open-ended therapy, in particular with a fluoroquinolone, is really just doesn't seem to be established and is theoretically unsafe, and so it makes me very, very nervous. There are children who are having great trouble and doing badly, and I will consider a trial to see if that's helpful, but I just have not put anyone on prolonged fluoroquinolone therapy. The duration of therapy is an important question, and I think in children who have severe symptoms and well-established streptococcal infection, you have to think back to the rheumatic fever model. And what is that model? That model is this kid's going to be treated until he or she is an adult. And whether it was age 18 or age 21, basically on average, children receive 15 years of suppressive antibiotic therapy. Now, admittedly, that was with amoxicillin and or penicillin G. But that was the model of acute rheumatic fever prophylaxis, and it was well known that relapses were due to poor compliance. And that's where injectable bicillin became so popular for suppression of this disease. So that was 15 years of shots in your butt. So it's about 225 injections, I guess, over a child's adolescence. So there is a history of prolonged antibiotic therapy. I don't tell parents that they're committed to treatment of that interval, but I certainly start it as an open-ended fashion, and I simply say, we'll see. I've had some kids who've had mild symptoms who've done well, and I've been willing to consider reducing therapy dosage or taking antibiotic holidays, particularly in the summertime when the risk of exposure to strep is lower in New England than at other times in the year. But I wouldn't say that that's a universally held practice. Yes?
I'm grateful you mentioned penicillin G, because I was going to ask you, people with poor compliance, is that still an option, weekly penicillin?
It is an option. I actually have not gone there. I don't know, Sue, if you have kids.
Only in our Sydenham's patients. I actually used to have to give the shots to our rheumatic fever patients when I was in pediatric practice in Chicago, and I couldn't do it after the first 3 or 4 because it's so awful. But
actually, if you mix it small amount with propane penicillin, it's much less painful. It really is worth it.
okay.
I've had to do it a few times in the really, really anxious, over-the-top kids who wouldn't swallow a pill. They wouldn't swallow food. I am. At least initially. And then when they get better, you can switch them out.
You didn't mention Zithromax, does that happen?
Oh, thank you. That was a Freudian slip, I think. So azithromycin is somewhere on that stepladder, for sure. In a child who's allergic to beta-lactams and has had hives to amoxicillin, the only way you'll know if they tolerate a cephalosporin is if they've seen a surgeon who's given them a cephalosporin despite the history of hives. And many kids, in fact, do fine, and their allergy is selective to penicillins and not to beta-lactams in general. But the teaching is if someone's had hives, you really don't have the freedom to give the beta-lactam of the other family. So we would often start with azithromycin. The thing about azithromycin is that, in fact, it's not a great strep drug. And whenever the issue of, is this PANS perhaps related to mycoplasma infection, or is this PANDAS in a penicillin allergic child, you can't have it both ways. The incidence of azithromycin resistance among group A strep is measurable, and it's real, and it varies from community to community. There was a paper in the New England Journal a number of years ago that the incidence of macrolide resistance among group A strep in the Pittsburgh area was 50%. I haven't seen that followed carefully over time, but it has a lower success rate against group A strep. It still works in most cases around here. I would make a ballpark guess that the resistance rate is in the 10% range. So it has an option, and the question is the dose. And I will treat with 10 mg per kilo for a short period of time, maybe for the 10 days of treatment, and then try to get kids down to a dose closer to 5 milligrams per kilo once a day. I've just been a little bit underwhelmed, although in children who have the syndrome and whose strep antibodies and or culture attempts have been unimpressive, I must say there have been children who I presume really did have mycoplasma associated illness because they really improved. And I begrudgingly have acknowledged that that has a real role to play. But if children are not allergic, I don't think about azithromycin much if the strep antibodies are supportive of the diagnosis.
And in those kids, we'll usually get a baseline EKG just to make sure they don't have a prolonged QT if, we're planning on using azithromycin for a longer period of time.
That was one of the clearest and most elegant discussions of the antibiotic treatment of this that I've heard. I'm wondering what role probiotics may play in treating this because we're altering the microbiome in the gut.
Let me say one sentence, then you can elaborate. I'm a big fan of probiotics. I think conceptually, we're learning that killing the gut flora for extended periods of time is not necessarily a great thing. And with each step higher on that ladder, we're basically killing more bacteria in the gut. So just conceptually, I think it's helpful. I think it reduces the frequency of antibiotic-associated diarrhea. So for children on long-term antibiotics, if their pooping is less of an issue, that's a good thing. But I think more globally speaking, there's a real role to play. I think how you operationalize that child by child just sort of depends, because sometimes getting them to take any medicine at all is a challenge. And I would hate to say now, to tell the parents, now your child has to take 2 medicines, and then have them sort of lose the fight, and what gets lost is the antibiotic. So I always ask, do your kids like yogurt? Because if nothing else, if they'll eat yogurt, that's a start. But I'm certainly in support of probiotics. I don't claim to know anything about probiotics beyond that, so I will pass the microphone.
We certainly have kids on prolonged antibiotics in the same course that Mark was talking about, as well as our Lyme kids that may be on multiple antibiotics. And we actually use probiotics very generously. I think there are several factors that are important with probiotics. Number one, it's colony-forming units that you're looking for, and it needs to be a high quality, high density of colony-forming units, in my opinion. If it is not refrigerated, those colonies are not as alive. So it needs to be a refrigerated product for the most part. There are some non-refrigerated products that are pretty good, but your refrigerated products are better, and higher colony-forming units, not milligrams listed or a proprietary blend. So, and I think, quite frankly, if you get a good high-quality probiotic, you can use sprinkles. Your VSL number 3, your custom probiotics, these are 150 to 450 billion units in a small packet. And you can just use sprinkles of that to get more like 25 billion, which may be, well, what the children need. And sprinkling on a small snack or dinner at a separate time of day than the antibiotics, I think can go a long way from preventing these kids. What we see a lot, because many of the kids that come to us have already been on antibiotics for quite a long period of time, what we see a lot is secondary yeast infections. And I think that can really be prevented with putting these kids on a probiotic at the same time as the antibiotics.
Dr. Pasternack, if we see a child who's negative ASO, strep, titers, etc., but is positive IgM mycoplasma, and they have a very definitive PANS presentation, would you go ahead and pursue the secondary testing? I mean, they're not, symptomatic pneumonia, but traditionally I've just gone ahead and started to treat them. Many of them respond pretty well. I've had some, as you know, I send your way that don't. But,
So I hope everyone heard the question about treating with macrolide on the basis of a positive mycoplasma IgM antibody titer. Let me begin by saying that I take all this antibody stuff with a grain of salt, that if you imagine a circle, a pie diagram cut into 4 quadrants, you can picture in one quadrant kids with elevated strep titers who do well with antibiotics against strep, kids with elevated strep titers who don't do well with antibiotics against strep. There turns out the other 2 are important as well. Kids with low anti-strep antibodies, some of them do great when they're given Keflex. And so I don't understand that, but I am a soft touch for an initial trial of antibiotics because I think a few weeks of therapy should be informative as to whether or not they're going to respond to antibiotic therapy. And then the final group, of course, are the kids with low antibody titers who don't respond to anti-strep antibiotic therapy. And you say, of course, you don't expect them to respond. They didn't have elevated strep titers. But the quadrant where there's low titers, but they do seem to get better, does exist, although it may not be a full quadrant. When it comes to mycoplasma, we've all been taught this is a short-lived infection, and that the notion that there's prolonged or lingering or subacute mycoplasma infection never landed in fertile ground. No one ever believed that. In fact, like many of the respiratory pathogens, the physiology is much more complicated than we appreciated. And mycoplasma has been demonstrated to persist within the respiratory epithelium much in the way that pertussis, for example, which was thought to be the classic colonizing, toxin-elaborating syndrome, that pertussis is really a poisoning due to pertussis toxin and not an invasive infection. It's actually not so true. You can demonstrate that the pertussis lives within the epithelium of the airway and that it reaches macrophages and can live in a prolonged state in an intracellular domain. Mycoplasma looks like it's got some of those same properties. So I've been less skeptical about prolonged mycoplasma infection. I simply don't know what to make of the IgM antibody titer that has a negative confirmatory test.
But what if they present to you though with a PANS kind of picture that's pretty?
So I'm willing. I'm not such a purist as I've said that I would restrict therapy only for the ones that have the elevated IgM antibody titer. But since so many parents are leery about antibiotic therapy in general, having that confirmatory IgM test be positive augments the argument that your child needs to be on azithromycin. And again, a trial of azithromycin for a period of time is going to answer the question. Because if they improve in a meaningful way, I think you've justified the use of the drug.
I just want to reiterate what Dr. Pasternack said about those quadrants. We've followed children now for up to 8 years, trying to see when their strep titers will move, and they don't. And Pat Cleary has just published a lovely paper, or at least it was in the poster form, showing that 2/3 of children with documented streps never have a titer rise in an ASO, an anti-strep DNase B, or an enolase. So in some ways, the strep titers are actually not very helpful if you miss 1/3 of the infections.
Dr. Swedo?
Yeah.
Where does IVIG therapy fall in with therapy for children with PANDAS?
That was a great question. Where does IVIG therapy fall in? I'm going to answer for Beth and then pass it back down the road, and she can correct me when it gets down to her. But I think that IVIG therapy is a very reasonable. Let's take Mark's ladder. That was actually a lovely, lovely way to think about this. So if you have a child who's got relatively mild symptoms, still getting to school every day, family life is disrupted but is not yet out of control, just antibiotics, lots of supportive therapy, and tough it out. The child who has moderately severe symptoms, sleeping with their parents every night, not sleeping with their parents every night, so the whole family is staying awake, any eating symptoms, and very grave concern that these symptoms are just rapidly escalating out of control. I think a trial of steroids would be the first thing that you might want to try. We actually used steroids in the Sydenham Korea treatment trial, got lovely results with the immunosuppressive dose similar to what you're used to using for asthma. The difference is that you'd probably want to continue it longer, and it may need as much as a month, because we used 10 days in our Sydenham trial, and the patients had a lovely suppression of their movements during the steroids, and then they rebounded. So I think if you continue more for a month, that would be great. So you've tried steroids, you've tried antibiotics, the child's still bad. or in that child who's moderately severely ill, right, and you're just very concerned, IVIG is a reasonable, maybe second line, but it's on that next ladder above steroids.
And how long would the effects of the steroids or the IVIG last?
So if it's a true PANDAS, and I think when we expanded it to PANS to include all acute onset syndrome, we actually went back to the very first paper that was published in this area was a case series by my colleague A.J. Allen, and that was all infections, varicella, influenza, as well as strep. And then because you don't know the etiologic trigger, you don't have as good an idea about the mechanism. And so I can't answer that question. However, if it's PANDAS, it's strep triggered, you can adequately prophylax against future strep infections. Once is enough. And I just went back and looked at my own notes from the early patients in that 1998 paper. And when we reported that they were all better at 1 year, they really were. Some of them had to go on to psychotropic medications, but we had only retreated 2 of the 30 kids during that year interval, and in both cases they had a very close exposure and were reinfected with strep. So IVIG, 1 course of probably 2 grams per kilogram on each of 2 consecutive days. And then the final level is the plasmapheresis. And I hope that the group will agree with Beth and I in May that if you have a child who has an acute onset eating disorder, especially some of our 5, 6, 7-year-olds, they literally stop eating and their life is in danger. Or the children who are having such out of control rages and aggressive behaviors that you're either afraid for their safety or a sibling's safety, plasmapheresis. And in that early trial, IVIG improved symptoms on average by about 40%, but it took a good 3 to 4 weeks. Our plasmapheresis group had on average 65% reduction in symptoms. And this is in comparison with the best drug treatment trials we've ever done, had a 23% improvement in symptoms. So very dramatic improvements after plasmapheresis. And it actually happens during the course of therapy. So we watched the kids get better as you pull it off. And I think it's because with Dr. Cunningham's results and all the rest, it really is clear that this is an cross-reactive, right? So you make antibodies against the strep, they get mixed up and they recognize these antigens in the brain. The plasmapheresis pulls off 95% of circulating antibodies over the course of 4.5 to 5 volume exchanges. And you have re-equilibrated in between, so you actually reduce your antibody load by over 50% with this course of therapy, and it's very effective. But it's obviously a big deal. You have to put a central line. Do you want to add anything?
All of it.
I just have one thing to add that I think is important to tell the parents, is that when you use the steroids, there will be no benefit the first week.
Right.
0. And you have to tell them that. So there's no benefit the first week, but the benefit kicks in the second week. So it's very important to, just hang in there. And these children generally don't become crazy on steroids.
Right.
It's very, very strange. My heme colleagues who do the pheresis at Georgetown, so we bring our patients in the hospital to induce them for leukemia treatment. We give them steroids and they go crazy. Your patients come in crazy, and we give them steroids and they calm down. So they don't usually develop really bad symptoms with steroids.
How many days do you give and what dosage of steroids?
I usually give like 2 milligrams per kilogram, but I rarely will go above 60 milligrams. And I give it BID no later than 3 p.m. for the second dose. And then I drop it in half the second week, and then I drop it to once a day the third week, and then I drop it to every other day the fourth week.
The only other thing we've seen with steroids, and you bring up the point of doing it earlier in the day, is increased disruption of the sleep early on. And just giving melatonin to help with going to sleep can be very helpful in general for these kids, but especially in that trial.
I think that when you're doing that, steroids are not sleeping anyway. I don't see any difference with the sleep. I tell them at 3 o'clock in the afternoon, but I don't think that makes much difference. The other thing is the tonsil, when you do the IVIG, they will have also a dust-up and symptoms right after the IVIG, because you're actually causing an inflammatory process. And I warn them about that. I say, in a week or two after IVIG, sometimes they will get a little bit worse.
And one of our colleagues, Miro Kovacevic, decreases that by giving a dose, at least one dose of steroids concomitant with IVIG.
I give more than that now. I give 2 doses. I give a big dose of solumendrol each day before the doses of IVIG, and I give the Toradol on the way out the door so that they don't get the headache. And I think it's certainly reduced the phone calls in the week after the IVIG. But I think it's helped. I don't know. I think it's helped.
And Dr. Pasternack, do you give IVIG at MGH?
Dr. Walter, my colleague, the immunologist in our group, is the one who coordinates IVIG therapy, and she's actually been finding it logistically more convenient for families and less costly to arrange it as a home infusion than to have kids come into the MGH infusion center to get treated. So she couldn't be here today, but she's actually, I wish I could say perfected, but she's on the road to having a practical way to do this at home.
Thank you.
How long does the plasmapheresis effect, and does it have to be repeated at some future date?
Plasmapheresis, like the IVIG, was just a single course of therapy, a single exchange. We did have in the plasma exchange group, we had one boy who, if we were showing slides, I'd actually show you his amazing shrinking caudate. When he came in, he had 98% of his waking hours consumed with OCD. His caudate was enlarged about 20% over expected for his age, sex, and weight. He had a complete symptom resolution with plasmapheresis, and his caudate size normalized. Like one of the girls in the IVIG group, he actually got reinfected. That time, his primary symptom was eating disorders, and we brought him back in for plasmapheresis. It didn't actually help his eating disorders, but in retrospect, I think he probably actually had mycoplasma at the time. Or mono. One of the things that you see in our college age kids is that when they get that wonderful combination of the strep and mono, they're in bad shape.
Would you comment on the kids who get plasmapheresis after chronic disease versus acute disease?
Sure. So plasmapheresis, in terms of we haven't done plasmapheresis. I know Beth has actually. In patients who've been sick much, much longer. Both of our trials for children in either their first episode, their initial episode, or their first exacerbation. And in the latest IVIG trial, they could only have been sick for 6 months in order to qualify. In the first trial, we did have some children who had been sick as long as a year, and they responded beautifully. Miro Kovacevic promised me, and we actually saw it in his records in his private practice outside Chicago, Illinois, that he has treated patients who have been sick for a decade or longer with an immunomodulatory therapy and gotten good results with just a single course of treatment. Again, one of the dads told me, we always learn everything from our parents, but one of the dads told me, you sit in the NIH and think that you've cured our kids, and we're home dealing with all of this stuff. So we've been much more careful after the second trial to actually touch base with our families every month for the 3 years after they've participated with us. And what we find is that indeed, yes, we cure them, we get their symptoms remarkably reduced with that initial course of IVIG, but then we do need to help do a lot of management in terms of changing courses of antibiotics, encouraging cognitive behavior therapy, use of psychotropic meds, and my analogy is sort of the full court press of basketball. You have to do both things at the same time, treat the symptoms and treat the cause.
What would be the expectable time course of response? Beth was enlightening me about this last night. For a kid who's had rather late detected, late treated PANDAS disease, who gets plasmapheresis, conceptually, since I was aware that plasmapheresis got rid of most of the circulating antibodies immediately, I thought, well, gee, we're going to start seeing a response very quickly, but Dr. Latimer was
don't
enlightening me
always.
that that's not the case. What would be the expected time course of response after plasmapheresis over weeks and months in terms of seeing a response if you're going to?
We've done probably about 80 kids. In my experiences, it's if the kids have been just recently sick, we get them fairly acutely. I have one child who was vomiting on the hour every hour. Every time he ate, he vomited. And he stopped, we have a protocol that we do 1.5 full body exchanges for a total of 4.5 full body exchanges over 4 days. So it was midway through the second one, he just stopped vomiting. That was the end of it. So, and kids who've been chronically ill, and I see them like a year later, usually I'll say, well, when did you really, and they're fine. And when did you really feel like you had things were really better? And they usually will say 4 to 5 months. That's usually what they'll tell me. They'll say 4 to 5 months.
Are there hints before that it's going to help? Is it a gradual response?
Yes, usually
Yes.
some of the objective stuff gets better quickly, like sleep gets better, the urinary frequency gets better, the general mood gets better, the kids come in, they're lighter, they don't have that horrible burdened look about them. But a lot of the other cognitive executive function stuff will hang around. And unfortunately, the tics take the longest to go away, and they're the most obvious. So when kids have really bad tics, the parents are talking about the tics. I'm like, stop talking about the tics. Don't look at them, ignore them. But
So
they do take a long time to go away.
the time course of response is actually very similar to the descriptions of response to immunomodulatory therapy for autoimmune encephalitis. And I just want to remind you guys as pediatricians, is incredibly helpful. And when we were talking about diagnostic tests, we didn't get into some of the other things that I'm becoming a believer that we all should be doing in children with an acute or even subacute onset of psychiatric symptoms. And that is a spinal tap. If you get pleocytosis, if you have an elevated white count, that's a pathognomonic sign of autoimmune encephalitis, and you can treat aggressively and should treat aggressively for AE. Similarly, MRI scans where T2 weighted images show any inflammation. And in our studies, prolonged EEGs, either overnight or even just a 24-hour video EEG, is going to show either some cases spikes and waves. In other cases, and probably more commonly, about 12 to 15% of the patients will have slowing, and that slowing is another pathognomonic sign of encephalitis. And then the final thing is a sleep study, and when I get back to the office tomorrow, I'll be working with Dr. Ashura Buckley. One of my colleagues has just finished a sleep series on Now. We're going to report 12 of them because we had to first decide if they were classic PANDAS, and then she wanted to look at the sleep, and of the 20 that we had done, we ruled out 8 as sort of not being comfortable that they were classic. So they'll get reported separately. But of these 12 children, 10 of them had abnormal sleep studies, and they had failure to establish atony during REM sleep. They continued to move. In some cases, it actually met criteria for REM behavior disorder, and other sleep architecture abnormalities, and at least the RBD, maybe Beth can correct me if I'm wrong, but I believe that the treatment of choice for REM behavior disorder is benzodiazepines. And we treated one of the children with that, just a 10-day course, and he didn't rebound.
It shortens REM time.
Maybe that's why.
Yeah.
Yes, sir.
You mentioned T2 a lot. I just wanted to throw in the flare sequence. Over the years, I have become incredibly disillusioned by our radiology colleagues. We defer to them, which I think is a horrible mistake. So flare sequences are extremely vital, and sagittal sequences are extremely vital. The radiologists and even neuroradiologists are so fixated on the axial sequence. That's all they generally see.
Yeah.
But that's not how the brain architecture is.
Right.
But our brain is not built in the axial plane.
Right.
So you've got to look at the sagittal sequences. Sagittal flares are extremely vital. I'm an MS neurologist, so I live and die by the sagittal flare sequence, but most people actually don't look at it at all. So given, I was just mentioning to Peggy before the start that I've been in MS now for about 30 years, starting as a medical student, and all of these discussions have this deja vu feeling to me, because this is exactly how it was 30 years ago in all MS conferences, when people were starting to grapple with the fact that this was a chronic autoimmune, due to autoimmune, Western autoimmune, inflammatory illness.
Could you all hear him in the
It's
back?
interesting you brought that up, because what we're finding in the tonsils is this very high IL-17, low Th1 values.
There you go.
Yeah. Could you hear him in the back? He was making a plea for sagittal flare sequences. And I thank you for that, because flare would actually be incredibly important here.
You just mentioned tonsils, and since that's a topic that we've covered yet, if some of you could talk, also Dr. Kathy Chon's here, or is she still here? There you are, who's been one of our local ENT specialist consultants for our kids with PANDAS. So that's been a question that comes up. I know parents bring that to the pediatrician a lot. So Beth, I think you've commented on tonsils a lot. If you could, some of you could talk about that, and also maybe Kathy, you could comment on tonsillectomy.
Yeah, I mean, we talked about this last night a little bit, but if it appears that the tonsils are chronically infected, either by appearance or then we just take them out, tonsils and adenoids, because there's a series of, if you have like so many infections in a year, take them out. If you have an infection in your tonsils that's affecting your brain, take it out. It's just, it seems like it's a no-brainer to me. And we do cultures actually at Georgetown. We take them out. We stop all antibiotics a week before, and we culture them all. And I'm not sure it's different than what you find in typical tonsils. We have tons of MRSA, but all kinds of weird stuff, serratia, actinomyces, lots of really bad stuff. But of course, these kids have been on antibiotics too, so, but not all the time. And but we do take the tonsils out, and particularly if we're going to do plasmapheresis, because we're going to make those kids immunodeficient. So if we're going to do that, or IVIG, because if we're going to take that leap and do an expensive treatment or immunomodulatory treatment, we want to make sure there's no infection anywhere before we go ahead and do that.
Dr. John, could you comment on what you've been seeing and experiencing?
Well, honestly, as an ENT, we're mostly the technicians in the community, where if we get sent to patients that it feels like the tonsils are affecting the child's life. Our concern is always that postoperatively some kids do very poorly. So that's always a concern with more than the parents, but really it's to you guys and the parents, and if you like it'll help, we'll do it.
How do they do badly afterwards, Dr. Chen?
Sometimes they flare, they have a...
They do flare afterwards. One thing that we have found to be very helpful at Georgetown is we give them a big dose of steroids going into this.
We do that anyways.
Oh, you do?
Yeah. So we haven't done that many recently, probably about 25 to 30, but a few have done very poorly afterwards, where for weeks and weeks they had acute symptoms. Whether that was triggered, I mean, surgery is no fun in general, so I'm sure there was some stress involved, but we try to give the steroids and the antibiotics. We warn parents.
Yeah, tell them. You have to just tell them. This is going to be terrible. Suck it up for a couple weeks.
Right. I mean, so for normal children,
Yeah.
so.
It's going to be bad.
Can I ask, what about the child who has tiny, beautiful, pristine-looking tonsils?
With
You
no
know, it doesn't matter,
infections?
can I just comment? For us, it doesn't matter what the tonsils look like, it's really how are they affecting the child's life. So even a child with perfect tonsils, they're telling me they're missing 20 to 30 days of school year, they're getting tests, we do have criteria, but in the end, if they are affecting the child's life, we'll take them.
That's good, because Pat Cleary's studies have shown that even those nice, tiny, good-looking tonsils often will have abscesses or pockets of pus.
Yeah, sometimes when you open them up, it's like they're bad. But we don't do it lightly. We don't do it in everybody.
My ENT colleagues, they get bonkers when I send a child over whose tonsils look okay. They don't mind the big gross ones, but that's what they're trained to do. But the little ones, I get paid. Mark, why is this child here? And I have to explain the whole PANDAS thing, and
Well, I'm
he's
here,
gotten it.
so obviously I'm a believer. Yeah.
Dr. Pasternack, your colleague, Dr. Geller, is doing a study on CBT with D-cycloserine. I was wondering if there's been any promising results.
I don't know of any ongoing information, so I can't share that with you, but I know he stays up late at night thinking of new ways to attack this problem, and he hasn't shared any of his recent results with me. I don't know, Sue, if you've...
That trial is actually based on an absolutely wonderful adult trial and a small pediatric case series from University of Florida. And I think it has great promise. In other trials, though, in anxiety disorders, the combination was not more effective than regular behavior therapy alone. So we'll see what he has, but he does need patients to finish it, so if we've got some, it would be good to send them to him.
Thank you.
I want to thank you for a fascinating discussion, and especially heartening to hear how you use clinical judgment as you go along. As a clinical psychologist, I've become incredibly impressed with how many of the disorders we see on a medical basis, and I wish more of my colleagues would come along. I do have a question. Given that PANDAS is still a rather controversial or contested illness, just wondering what kind of lack of blowback we get either from insurance companies or from colleagues when we use the extended course of antibiotics, especially given the current climate and worry about antibiotic resistance, and how you handle that.
In our experience, we do have tremendous pushback, and we try to share the knowledge, the literature that's out there, and it really comes down to the improvement of the kid, the N of 1, and if we can prove that this particular child has done better with what we're doing and show both the rheumatic fever literature, Madeleine's testing, then we get some, we have a whole packet together to give to the pediatricians. Sometimes they still resist, but they say, okay, you prescribe it and we'll let it go. But that's what we try to do at least.
And I'm so glad that you're here because, as I said, I am a very firm believer in the full court press, and for the psychologists to be our partners in trying to treat these kids is so essential that every single child who's participated in one of our treatment trials or even our antibiotic trials has been referred to a behavior therapist to get CBT. And those who actually went or were able to find one, equally problematic, did much better in the long term than those who hadn't, including a young woman that I met at the November meeting who had been one of our patients and talked about how we had pushed her so hard to get CBT, and she went sort of very reluctantly, is a polite way of saying it. But now that she was in her late 20s, she thought that this was the best thing that had happened to her, that she used her CBT techniques not just to fight off the little flares of OCD, but also to really manage other areas of her life. So thank you.
Because there's comorbidity with the psychiatric symptoms, when do you think it's good to, because you mentioned psychotropics, and as I'm a clinical psychologist as well, work with these kids, and the obsessive ideation is so profound. I get kids that almost can't get off the thought.
Right.
So, and I understand it's an inflammatory disease that affects the way our brain mediates information and perception. So, when are those medicines introduced? And as a clinician working with that, what am I working with? Because I'm working with an inflammatory illness that presents itself like a psychiatric illness.
Right.
So I'm kind of...
Exactly, and the latest literature shows that the vast majority of psychiatric illnesses are probably going to end up either in the neurodevelopmental category or in the inflammatory category. So I think this is just the tip of the iceberg. The simple answer to your question is that the psychotropics should start as soon as the child can tolerate them, And they're going to tolerate them much better if you start at an incredibly low dose. And I'm talking maybe 1/20th of the normal dose of an SSRI for treatment of their OCD symptoms, and gradually increase. And those of us who use SSRIs know that there are some that are activating, and the side effects listed are akathisia. There's some that are more sedating. You want to choose one that's sedating. You certainly don't want to choose one that's going to make the child feel revved up inside, because they already feel that way. I mentioned benzodiazepines. We're actually going to get together in May to talk about doing an actual trial of this, unless the sleep data can give us an excuse to just do it on a clinical basis. We haven't traditionally used them. I'm a pediatrician by training, and my experience with benzos in kids was worse than Benadryl in kids. That you would set them off and they would have that idiosyncratic reaction, and you'd have a wild person on your hands for the next 12 hours. But because we were doing spinal taps on all of our patients twice during this last trial, we used a lot of Ativan to get them through the LP, and discovered it actually, we had only one out of the 30 children, so out of 60 doses, only one child had an idiosyncratic reaction. And for many of them, it was the first time that they had had a good sleep and some rest. So I don't think we have to be as scared of them as we used to be. Madeleine's data would show that maybe the dopaminergic agents might be helpful, and in the Sydenham Korea trial, we used a lot of Haldol. The Haldol didn't actually help the movements that much, but did help some of the anxiety. And if we remember, the antipsychotics were originally described as major tranquilizers, so maybe that's why. But Beth, do you, or Nancy?
Yeah, I think there is a role for benzos in these kids for sure. And sometimes when the kids are coming into the office, even the short-acting oral Versed, you don't have any problems with it. It's shocking. But the one thing I would say is that you don't have to worry about a dystonic reaction from risperidone in these kids. They have so much dopamine, they could lift up a Volkswagen. So if risperidone M-tabs, when they have a huge meltdown that melts in the mouth and works very quickly, has been very, very, very helpful, particularly in the office, because they just melts and it works within a minute or two. And those are very helpful. And you don't have to worry about just giving a 0.125 dose or a 0.2. You can give a little guy 0.5 milligrams, and they're going to still be wide awake and looking at you because their dopamine levels are just sky high.
Dr. Latimer, you mentioned epidemics of PANDAS in certain areas. Do you think that there are certain subgroups of strep that are causing this more often?
I don't know what's causing that, because we can't get anybody to look at it. I mean, it's similar to the rheumatic fever in Utah, but we have definitely clusters.
I think that's exactly right. The epidemiology of acute rheumatic fever has been shown to have periodic flares that typically correlate with novel clones of group-based strep with unique M protein determinants and so on. And the problem for us nowadays is that so often the diagnosis of strep pharyngitis is made by rapid strep tests, that the isolate there's no isolate. So no one cultures and no one has a bacterium to be studied. The other half of the problem is no one's been interested in studying them. We're interested, but we would love at some point to be able to bank these strains and to subject them to the kind of molecular phenotyping that would allow us to say certain phenotypes of group-based strep may in fact be pandagenic in the way that others were characterized as nephritogenic or as rheumatogenic years ago. The problem is M1, which is the most common, has been associated with all of them. So I think there's a relative propensity and not an absolute propensity for one strain to do this, that, or the other. But I'm convinced that this is a rich load to be mined, and it's just a matter of marshaling the resources and the culture to do this.
Right, so with Mark's help and the NIH Clinical Center Laboratory, our head of microbiology is very interested in helping to track down this problem. And so if you have any patients in your practice, do the 2 swabs and do your overnight culture. If that child is a PANDAS and that culture is positive, as soon as that happens, we'll get you our contact information, and you just contact us, and our micro lab will actually send out the slant so that we can then bring it back to the NIH, and we're just going to bank them there until we can bank them other places. But
there is a cohort that's been identified in Duxbury, and we have contacted the Department of Public Health. They are interested in studying it, and they will be in contact also with Dr. Pasternack. So I have to get them some record data, because they need diagnoses, and that may involve then hopefully maybe bringing an IH as well. But they are interested, and so we hope that goes somewhere. That goes to my other question. One of the parents had for all of you, which is the Duxbury children share a pool experience in 3rd and 4th grade. And we've heard recently that one study about strep on pasta at a dinner. The sports team that had everybody infected. Is there an area like a pool, or, you know, of course we have them in the school, that's clear, but that might foment or support it? I always think of pools as an antiseptic with all the chlorine, but is there any thought that that should be, as part of the pursuant, looked at?
The pool water itself is probably not the problem, but it may be that they're all drinking out of the same drinking fountain as soon as they get out of that pool.
Well, I'm always thinking of the runny noses when you get out of the pool as well.
I'm not aware of any group A strep epidemics linked to chlorinated sort of public swimming water, but it's a searchable question. But I
actually
agree.
did search that a while ago, because when I took my virology class, my final exam had that question, how you would take out the other's swim team at a meet, and could you use the pool? We had a very twisted professor. And so I actually looked at strep at the same time and couldn't find anything, but that literature may just be lacking.
Just on your benzodiazepine question, in child psychiatry psychopharmacology literature, in the last 3 years, there's been an appeal from the people who published those papers, Brown and one group out of Canada, for more liberal use of benzodiazepines in children, that it's far undertreated. Children are left in far more highly anxious fight, flight, panic states than adults are, and that the appeal is to be less restrictive and more generous in your thinking about use of benzos.
In the Northeast, I would say that it applies to adults as well. They find benzodiazepine use is extremely frowned upon.
Yeah. I have colleagues
As
who
a
won't
neurologist,
use
I
it.
put a lot of my patients on that for various reasons. So it's mostly an MS population, so it's for, spastic hugs and, severe spasticity when is not enough. But they also have anxiety issues, and the benzodiazepine works well. But you always get screaming phone calls from psychiatrists.
Yes,
The one drug that we didn't
adult
mention.
Psychiatrists have to agree that there's a terrible prejudice against benzo use in adults as well. And there's a misconception that, well, they're anxious, so throw some Paxil or Prozac. And so many times the acute reactions to the SSRIs are actually agitation and anxiety just from the akathisia-like effect, etc. So it's not just kids, it's adults too. And it's hard to fight that because it's sort of like a Puritan philosophy, which is, I don't know quite where it comes from.
Is it concern about dependence?
Yes. There's the concern about dependence is so it's just escalated to the point where
it's a belief system.
Yeah.
I actually heard a
People
wonderful
who
lecture on the difference between dependence and addiction,
Yes.
and the statistics show that 95% of physicians don't know that there's a difference.
In the Northeast, it's 100%.
Maybe that's where the survey was done.
I know you and the blue have been wanting to ask.
Well, so I'm a general pediatrician in the room, and so when I think about this list of symptoms, I could fill up that Mass General clinic in about 30 seconds. So can you help me prioritize, like who specifically? Like you mentioned, okay, of the 30, 12 we think really had it, and the other 8. Like, I mean, acute separation anxiety, sleep problems. It sounds to me like they have to first start and definitely have like OCD and eating, anorexia of acute onset before I even think about any of the others. Like you mentioned, the urinary frequency. I mean, I get calls about urinary frequency all the time that are not UTI and not diabetes related. Am I supposed to be like tracking these kids for possible future PANDAS?
No, all you have to do is do a throat culture when you get those calls, because that's what Picciocchiero did. So you don't have to send them to the clinic, but you're exactly right. How big is this problem?
How big is this problem, or how?
It may be as big as 10% of children.
Do a throat culture.
It's a big
there's
problem.
so many kids that have strep.
Yes, but the actual
and I don't know
carrier
if that's
rate,
PANDAS. If they have strep and they have urinary frequency,
It may be PANDAS. So
But
the
how is it
actual
so
carrier
particularly-
rate of the actual carrier rate of strep is only about 5% of the population. So I've tried to convince people that this is a differential expression of strep rather than an asymptomatic infection or a carrier state. If you get that call about the urinary frequency, that's actually the child that we hope you will culture their throat and treat the strep, because it will obliterate their symptoms and may protect them from having this generalized antibody response that you run into real trouble with later, where after a number of exposures to the group A strep, the antibody response, maybe Madeleine can bum me out here, generalizes to the point where they respond to other infections, psychosocial stressors, vaccines to some extent. Any immune trigger will be setting this off. So when I said it could be as many as 10% of the children, that's from our study in a Virginia school and Dr. Tanya Murphy's study down in Putnam County, Florida, where we did behavioral observations monthly in the classrooms, and Dr. Murphy did the behavioral observations plus had the opportunity to get strep throat cultures. And in children who were strep positive, it was very highly correlated with the adventitious movements and hyperactivity, behavior problems. She didn't have an opportunity to look for anxiety. In our study, 10% of the children during the strep months had visible tics and hyperactivity, which decreased to less than 4% during the spring months when there wasn't strep in that school. So I think that subclinical sort of early episodes are incredibly common, but we don't actually have any epidemiologic data to prove that that's true.
So can you describe how you do the choreiform exam, because it's so fine when you see it?
I would love to actually, I'll show you, but then I'm going to pull up my computer and we can pass it around so you can look, because we actually have a teaching tape of the difference between choreiform movements, which are fine piano playing movements, just more distal, and then the chorea, and my dear friend Dr. Latimer helped me to make sure that we were identifying these right, but chorea is an involuntary movement every time you try to make a voluntary movement, and it becomes very proximal, lots of truncal instability, whereas these kids are just doing this. Now, if you have a patient that's only 4 or 5, you don't need to bother doing this because it's normal up until the age of 6. And once we really started paying attention to the behavioral regression, I wonder if it isn't just a release of an earlier developmental marker.
They're hypotonic too.
Yes, and they can also be kind of hypotonic and floppy. And you've found decreased reflexes, haven't you? In some?
Yeah, well, because of the hypotonia, they have decreased reflexes. They're a little like praxic too. If you try to get them to follow you in the exam, they just...
Yeah, they're just new
they're
clumsiness.
just not following you.
So I'm sorry, can I just follow up for a minute?
Yeah.
So the variety of other symptoms that are not OCD and not anorexia that are maybe precursor symptoms. So I bring the patient in, they don't have strep infection. Do I go further than that? Do I look for ASO and just...
I wouldn't do titers,
Okay.
and if it's subclinical enough that things are manageable and in good shape, I personally would go ahead and give a 3-week course of antibiotics, but I'll let Nancy. Mark?
We have a checklist that we of about 10 things that just our office manager or whoever is answering the phone has, and if it's an acute onset and one of the things on the checklist, they'll come in for a strep culture first. And we'll take a look. Some of them have perianal, and not and we'll culture that if that's positive. But if they meet, a few of these criteria, we'll treat them. And if those symptoms get better, those are our kids. But we're maybe more than our colleagues. We're quicker to treat because we've seen a lot more at the end. After several bouts that are much more severe.
I probably wouldn't treat on just one symptom. So if it's just maybe I would on urinary, but in all the rest, no. So acute onset of only separation anxiety, I would look for an infectious etiology, but then I'd start looking for all the other etiologies that could give you separation anxiety. On the other hand, if that child's also regressed, they're having new onset sleep difficulties, urinary symptoms, and have at least 2 or 3 of this complex, then I would
But even if they don't have any clear OCD.
I think the OCD, and I'll let Sue speak to it, I think the OCD, and even in the Yale study, it wasn't that big of a problem, because there's the Yale-Brown OCD scale, and they had to rise to a level of 20 on that scale, which was moderate to severe OCD. A lot of the kids don't come to that level of OCD, even though their separation anxiety is horrible, they're impulsive, they're ready to jump out the window, they're grabbing a knife with their sibling, their dysgraphia is horrible, they have urinary frequency, they have everything else, but they don't have the OCD, which gets them to that level.
Or they won't tell you. So as long as they're still in control, the OCD of PANDAS is exactly the same as general obsessive compulsive disorder. And that is, it's a disorder of rational irrationality, so that the patients recognize their symptoms as crazy and they try to hide them. So online, anywhere, if you just Google YBOC symptom checklist, the Yale-Brown obsessive compulsive symptom checklist, there's a 2-page list of obsessions and compulsions, and for all of our kids who are 5 or 6, we read it to them, and for the kids who are old enough to read it themselves, we let them just check it off. It asks for past symptoms and current symptoms, and you'll be surprised what they put down there, and it's also quite helpful to them to see that other children have had these symptoms and that they're not as alone in their presumed insanity as they think.
One way to elicit those symptoms, and this is what I generally do with the kids, is I say, a lot of kids with this have a lot of bad thoughts, like when you get a song stuck in your head. So some of the bad thoughts are about religious things, people dying, sexual things you know you shouldn't be thinking about. I don't care what the thoughts are, I just need to know if you're having them.
Yeah.
You don't have to tell me what they are, I just need to know if you're having them.
Or the parents will tell you that the child suddenly is asking for reassurance all the time.
Yeah.
And you might think that that's more just separation anxiety, but it isn't. It's, am I bad? Did I do that right? Did I do that right? Did I maybe hurt that person?
Yeah.
And that's a very common symptom in our PANDAS kids who are 4 or
Issue
5.
of tick too, because although it kind of got removed off the PANS diagnosis, it still presents what I see as a prominent entry point for many families.
Beth, do you want to address the ticks?
The issue, yes, the kids with, I think, the kids with PANDAS-related ticks come on in an explosive fashion, as opposed to the child with, well, I don't know, Tourette's, I guess.
Emerging.
But it used to be 15 or 20 years ago, you'd see somebody come in, your eye would blink a little bit, a 10-month-old might have a little bit of eye rolling, an ocular tic, and then they would just sort of slowly evolve. Or you might see a child who's got some ADHD and you put them on a stimulant and then they start to have some tics. It was kind of just, it was manageable. Nothing came in explosive. But now you see children who will find one day and they come in, Mom, it's this huge explosion of violent tics. And I have 3 kids right now I'm trying to manage who are just completely out of control. One with explosive vocal tics, one who can't stop her head. I think actually she's going to get a neck injury if we can't get it under control. But it's an explosive onset of severe tics, and we don't see that with typical Tourette's. You just don't see it. It does present that way.
I also want to say that we're living in a Lyme endemic area, and when some of these suspicious symptoms come up, Lyme disease on the differential, ask about tick exposures and behavioral outdoor pets.
A lot of kids, it turns out, sleep with their pets as a way to keep them in bed. Parents tell me. So also there's a lot of ticks dropping off of the animals.
Different kind of tick.
It is, but
Yeah.
still a lot of tick.
Sometimes they sleep with their siblings too.
Yeah.
So instead of their parents, so,
Or
which is
in
fine.
the backyard in
Yeah.
the summer.
Yeah.
Like the leaves.
Can you comment on vaccines? I have a lot of families who have a child diagnosed with PANS or PANDAS, and they get concerned about vaccinating that child or about vaccinating siblings. Is there any association, especially with live virus vaccines, as being a potential trigger for this?
We've had an outbreak in measles in the New York area in a couple of groups, and we've had that concern. But we strongly recommended to those families to give the vaccine, and so far, all of them have been absolutely fine. I mean, the flare that they would get from the disease itself, if they were going to get a flare, would be much worse. We do have a vaccine protocol where we try to support the child with increased antioxidants, but certainly those on antibiotic prophylaxis, we don't have any concerns about those. If they're acutely ill, we certainly try not to do it at that point in time. But I don't know if anybody else wants to comment.
I think it's safe to say that everyone on this panel is on the pro-vaccine front. That's on the forums, but that there's no one in the community of PANDAS who's against vaccinations.
Do you want to talk about your piles at Thanksgiving?
Yeah, I do think there are times when you have these exacerbations, and during the, and I've been taking care of these kids for over a decade now, and there are these little flares during the year. The first flare is usually in September, end of September, early October, and the swine flu year was just a nightmare. But they go back to school, they get exposed, and they all come in, and after Thanksgiving, it's nothing like after Thanksgiving. I think they go visit their cousins. They all sleep together, and they get whatever the cousins have, and then they come back. And between Thanksgiving and Christmas, it's a nightmare. It's an absolute nightmare. And I don't see the same thing after Christmas, but I see it after Thanksgiving. Almost every year.
When I see them, I see
you
them
go
in
visit them
January.
and stay in a hotel. Do not sleep with your cousins.
In MS, it's the same. It's a bimodal peak, but the biggest peak is between October and December. So,
When's the other one?
April.
April?
End of when winter ends. So winter is usually a very quiet time for MS, but it's actually a very bad time for subarachnoid temperatures.
Yeah.
But yeah, all are inflammatory neurological diseases flare in October.
I think that brings up an interesting point, though, in these kids that have an autoimmune profile. Any change in season, change in exposures, and I think these pockets, not only do we need to look at the strep, we need to look at other things they may be exposed to, whether it be molds or other germs, seasonal changes. I think once they have this profile, we need to look at multiple things systematically.
And that also explains why the focus on vaccination is the wrong model. So the immune system is very non-linear. So it really doesn't work as, I gave this one agent and therefore I got this one response. I gave this child a vaccine and it got this disease. That really doesn't apply to any of the immunological diseases. So the child is probably safer with the vaccine.
Well, the other thing I tell all the parents with vaccinations is that when you got that vaccination, that's not the only thing that happened that day. You went to the pediatrician's office with a 15-month-old who touched everything in the place, got exposed to everything, probably went to McDonald's, jumped in the balls. It's a major day of exposure. They weren't just sitting home with mom that day. So they could have been exposed to other infection, other triggers that day.
It's not a linear relationship at all.
Yeah.
Beth Latimer, you were talking before about resveratrol and these kids have so much dopamine, etc. What about the sensitivity? Is there hyper or hyposensitivity of the dopamine receptors to these kids as well? How do you think the receptors are changed, if at all, having all this dopamine around?
That's a question for Madeleine, the D1 receptor.
Well, actually, is this on? Yes. We know more about what the antibodies actually do. When they signal the CAM kinase, that pathway leads to increased dopamine release. And we've been able to use human monoclonal antibodies produced from the patients to show that if you put the antibody onto neuronal cells, you'll get much increased dopamine produced. And in addition, the antibodies to the D1 receptor actually bind and make it 100 times more sensitive to the dopamine. So you've got a child that's making too much. If they have both antibodies, they're making too much dopamine with the anti-D2, and then they're actually making, you have all this dopamine around, and the D1 becomes much more sensitive to all that extra dopamine, and so they just go crazy. You know, we are
D2 as well? Have you identified
right.
both?
D2, the CAM kinase goes to D2 and D1 actually are probably expressed. We don't have all the answers on that yet. Are probably expressed as a heterodimer on the neuronal cell together. So if you have antibodies to both, you probably have an even more highly signaling event for the child. But for the D2, you're making a lot of dopamine. For the D1, you're actually causing it to be much more sensitive to all that dopamine that's around. That's at least the mechanisms we've been able to show. The D1 data is not published yet, but the D2 is just recently. So I hope that helps a little bit.
The clinical implications of that, though, is that you never put one of these children on an amphetamine.
Right, and stimulants.
These, that's the worst possible thing you can do.
During acute illness.
During an acute flare, even though they often look really ADHD and impulsive and like they're jumping on things and doing crazy stuff. Intuitive is okay, Risperdal is okay, the benzos are okay. But you cannot put them on an amphetamine.
But what about in terms of thinking down the line, risk of tardive dyskinesia? So if you're thinking you've got these kids who are very sensitive to dopamine, I would wonder whether neuroleptics I wonder if that would increase, say, their risk for tardive dyskinesia. And I know it's too early to even look at it. But if you do have a kid who's hypersensitive to dopamine and they're on neuroleptics for a while, and then they stop them, my question is what would happen? Would there be a rebound? And they would be at a higher risk for disc lesions and other abnormal movements?
It's only extrapolation from the literature, but the fact that tardive dyskinesias are extremely rare in patients with Tourette syndrome who are on these neuroleptics for very long periods of time would suggest that it isn't actually an increased risk in the PANDAS patients. Because in Harvey Singer's clinic, 10% of his Tourette's actually met criteria for PANDAS when he went in and looked. So I think that it should in general be safe. On the other, having said that, we have seen a couple of children who had an oculogyric crisis as a result of their medication, so you do need to be cautious as treating them.
In terms of tick suppression, risperidone is going to be more potent than other antipsychotics, but in terms of OCD, Abilify above the other antipsychotics has shown a little more response. This is particularly true if you have to treat an you have an OCD kid who can't tolerate SSRIs. You find out very quickly amongst the antipsychotics that small dose Abilify often has an edge for OCD over the other antipsychotics. It's not as good as the D2 blockade in terms of tick, but if you're looking at an option, or again, reducing agitation in the OCD, again, starting very low and very slow.
And 15% of these kids have frank hallucinations and some paranoid delusions, so their hallucinations can be very troubling to them.
And they're obsessively psychotic. I mean, it's worse than the average.
I've had a pre-adolescent teenager who had a pre-diagnosed ADHD, developed symptoms of PANDAS, did terrible, went on her stimulant, and I switched her to Strattera, and she did quite well. And I think, maybe I'm incorrect, but Strattera has some dopaminergic properties.
Noradrenergic.
Noradrenergic. So would there be a reason as to why Strattera would?
Well, it's noradrenergic. It says SNRI to start with, so you already have anti-anxiety, antidepressive properties in the drug, and it's not directly stimulative of dopamine. There's probably a secondary effect, but it's mostly noradrenergic, which is known to help with focus and attention. But it's a great drug, for example, for anxious ADHDers that aren't hugely hyperactive anyway, because of those same properties.
I'd like to just mention that as a very traditionally trained neuropsychopharmacologist here in Boston, I also try to keep another foot in a camp that Nancy has a foot in, and that's sort of complementary alternative medicine. And there is a professor of microbiology and pharmacology at Tufts who has treated mast cell disease for a number of years. and is interested, mast cells are extremely pro-inflammatory in the brain. And he has developed a product that is a bioflavonoid that is a natural substance, and he believes it has potent anti-inflammatory effects. I, a year ago, had a child that Peggy and I used to share together, diagnosed with autism, who suddenly developed PANDAS at Thanksgiving time. I was actually on a train going to New York City to be with family when Mom called. And when I saw him in the office the following week, he clearly had ticks. I treated him with antibiotics. He had been on some benzodiazepines, but I decided to add this Dr. Fioridi's Neuroprotect, which has luteolin in it, which is a bioflavonoid. And Mother progressively raised the dose to 6 tablets a day. Because it's somewhat expensive, she tried to stop it after 2, and let me just say, his tics gradually went away, and I was able to take her the haloperidol. She tried to then take her the Neuroprotect, and within a week, the tics came back. So there are these other compounds that occur naturally within nature that have anti-inflammatory properties that I think we need to be paying attention to as well, and the research needs to focus on some of those.
Let me just say we're a little past 9 o'clock, or quite a bit past 9 o'clock. It's 9:30, so I think we need to wrap up. If there's anything else anybody want to put a plug in for or say, and then also if people can stay around, Dr. Swedo has a video, Dr. Cunningham has a video that might be of interest to this one. And I really want to emphasize for our parents group that we really, really appreciate all of you coming this morning. We hope you spread the gospel amongst your practices and your colleagues, and we're always available to try and hook you up with these very wonderful speakers if you need to have a personal discussion with any of them. So thank you again for coming this morning.